Good evening, everyone. Myself, Dr. Neeraj Thapa. Currently, I'm doing my internship at Nepal Medical College and Teaching Hospital, Jorpati.
Hello and namaste, everyone. I am Eliza Dulal, third-year medical student at Kathmandu University, School of Medical Sciences, Dhulikhel.
First up, I would like to welcome everyone. Thank you all for joining us. And special thanks to Dr. Prakriti Urja, who despite her hectic schedule, managed us a time to interact. And also special thanks to our Jagu Didi, who is also my alumna. And she has been helping lots and lots of medical students through this kinds of program. And we are also very much thankful to Medical Student Support Group for providing us an opportunity to moderate this program.
आजको सेसनमा चाहिँ हामीसँग कार्डियोलोजिस्ट डाक्टर प्रकृति ऊर्जा म्याम हुनुहुन्छ. She has done her residency and fellowship in cardiovascular diseases from Creighton University Medical Center, Omaha, and she is currently an attending physician in Faith Regional Cardiovascular Institute. Thank you for joining us, ma'am. Welcome to today's session.
Thank you. Thank you for the introduction.
Medical Student Support Group has conducted many medical series with many expertise in the past. So as a part of this series, today we are discussing on basic of CBS examination. So if you have any queries, you can put that right in the comment section, or we'll discuss that after the lecture is over. Also at the end, we'll discuss career as a cardiologist in the United States. And so without any further delay, I would like to move forward to our program. Dr. Prakriti, the floor is all yours.
Okay, thank you. Thank you for letting me be here. Thank you, Didi, for organizing this. Okay, you can write, what is the most difficult part of cardiology that you feel? You guys can respond to this. This is for like, aileko लागि पनि र future ko लागि पनि त्यो गर्न खोज्यो. Okay. Good. My favorite topic, EKG. Murmur, ECG, murmur. Basics plus ECG.
Royal look, like saying, I think he's confused about how to respond.
Oh, it's fine. Remembering all the blood pressure and the course, ECG, heart sound. Okay, good. So it's pretty much the same topic. Sabaile praja jaso yahi topic harla nai difficult one. So at least we will be able to cover one part of it. Okay. So now the response. Okay, now some brain bites. This is, I'm actually telling it brain bites because this is gonna tune your mind towards what type of thing we are gonna address today. And it is also going like making you, it's gonna make your brain like excited about what you're gonna learn. Okay, it's gonna be question as well through poll everywhere. And okay. So this is the first question, which needs further evaluation? I'm giving you time for the option just to see. It's a 2/6 diastolic murmur in a 25-year-old male, 2/6 systolic murmur in 25-year-old pregnant woman in medicine. So y'all are smart. What I'm going to talk about today is rationally behind what is the cardiovascular examination, so that when you actually see the patient, it becomes like intuitive or second nature for you for the cardiovascular examination and to say the findings. And we will also discuss pointing towards like how can we answer the board questions, like examination based question. मलाई त्यहाँको चाहिँ सोध्छ तिमीहरूलाई यो क्वेशनहरु कार्डियोभास्कुलर एक्जामिनेसन बेस्ड क्वेशनहरु एनीवन फाइनल इयरमा मेडिसिनमा सोध्छ तिमीहरूलाई
एमसीक्यूहरु सोध्छ दिदी
So hopefully you'll be able to answer these with that. Yeah, internal medicine ko board ko final exam, board certification exam ma ekdam dherai soch cha yo question haru. Okay. So now decoding the cardiac murmur, I am going to present it in a steps just to remember and make it easy. Step 1 is know where the blood is flowing. Just to कुनै पनि murmur कहाँ कस्तो हुन्छ भन्नेलाई बुझ्नलाई just you have to know where the blood is flowing. This is a cartoon of systolic and diastolic. We all know that systole is a phase where heart contracts. So any outlet valve, when heart contracts, the blood flow outside from the heart. So all the outlet valves are actually open during this duration. And then diastole is the phase where heart relaxes. So when the heart is relaxing, it is actually receiving the blood from all over the body. So all the inlet valves are actually open during this phase. So step 2 is now we have to know which valve opens well. This is a nice diagram. Sorry, it's a little blurry, but here we can see that in systole, can you see my cursor? Yes, ma'am.
Yes, ma'am.
Okay. So here's the systole. So systole, what happens is blood is pumping the heart is pumping the blood. So outlet valve is going to be open. That will be aortic valve and pulmonary valve. Those two are outlet valves. Then diastole, it will be receiving the blood. So it will be inlet valve. So it will be tricuspid valve and mitral valve will be open during diastole. So this is easy to remember if you remember from outlet and inlet perspective. Why knowing this is important? Because we have to remember two things to differentiate which murmur is what. First thing is stenosis murmur occurs when the valve is open. Stenosis bhaneko chahi it's narrowing of the valve. So it happens when the valve is actually supposed to be open. Usually kina huncha bhane if there is a decrease in the area of the valve, there will be turbulence, and it depends on the Bernoulli's principle. So Bernoulli's principle, this is like, it just says that imagine तिमीहरुले चाहिँ एउटा पाइपबाट पानी पठाइराछ भने त्यो ठुलो पाइपलाई कुनै ठाउँबाट सानो गर्दियो भने त्यो सानो पार्टमा चाहिँ एकदम धेरै फ्लो हुन्छ हैन त्यो किनभने त्यो पुरै वाटरको फोर्स त्यहाँबाट आउँछ त्यही भएर प्रेशर बढ्छ त्यो प्रेशरले चाहिँ टर्बुलेन्स क्रिएट गरेर त्यो साउन्ड आउने हो है If you are interested in cardio, you're going to hear this Bernoulli's equation all through your life, like entire life. But for now, you guys don't have to remember it. And you will not need to remember Bernoulli's equation to remember that stenosis murmur occurs when the heart valve is open. And that is because of the turbulence across the valve. Okay. And second point to remember is regurgitant murmur occurs when the valve is closed. When the valve is supposed to be closed, at that point, regurgitant murmur occurs. And the reason it occurs is because blood continues to flow from the small residual opening in the heart. So this is an echocardiogram. This is a transesophageal echocardiogram. This is done through the esophagus. And here, just to orient, this is the left atrium, left ventricle, and this is aorta. Okay, so if I'm going to open this, you can see the video, right? Okay. So let's stop it, and I'm going to show you here. So the valve is open here, right? You can see the valve is open. This is the valve leaflet. So it's open, so blood is flowing. There is no turbulence. It's like nice and flow. Now here, the valve is supposed to be closed here. Here, the valve is supposed to be closed. But due to some reason, there is some gap. Can you see the cursor here? So these are the gaps. So through this gap, you can see there is a blood flowing. This turbulent jet, this is actually the blood flow towards which is regurgitating back in the atrium. So that is why regurgitant murmur, you can hear them when the valve is supposed to be closed. Okay. So you don't have to take note. You can actually, I can give this presentation, and Jagu Didi has the recording too. Okay. So now, okay, now we'll go for the step 4. The step 4 is know the location. Why it is important is because, forward. So usually this is how the heart is located. I'm sure all of you are aware about it. But one thing to notice that this is the pulmonary artery. So pulmonary artery is, even though it's a right structure, it actually comes towards left, which is very important. And it gets pretty confusing initially when you are studying that. So it comes towards the left side, and this is the aorta. This is how the heart is located. And then, so the pulmonary pulmonary valve, if I can have my, so pulmonary valve will be between this, will be in the left side, because it will be next to, just between that pulmonary aorta and right ventricle. Sorry, pulmonary artery and right ventricle. And aorta will be in the right side. Mouse-le कामै गर्न छोड्यो. Okay. I will do this. So, okay. That is why this, you can just, that is how, if you remember that previous image, you can easily remember. So this one at the right side of the sternal region, it will be second intercostal space, it will be aortic valve murmurs. And in the second intercostal space, in the left side of the intercostal space, it will be pulmonary valve murmur. As like you can clearly see that this is the left, this is the right. Then mitral valve, this is the atrium, right atrium, and this is the right ventricle. So mitral valve will be located, tricuspid valve is located somewhere here, and mitral valve is located somewhere behind this area. So that is why you can hear the tricuspid murmur at the right side and here, and the mitral murmur at this side. So it's easy to remember, like all patient takes medicine, if in case you forget, okay? During the exam, all patient takes medicine, okay? Now, this is a long list of murmur. I'm not going to go through this because it's in every book and you guys know this very well. Now it's time for your stethoscope. I'm going to ask questions. So okay.
At the second right intercostal space and does not change with respiration. It may radiate to the carotid artery, especially the right carotid.
So initial 3 beats is going to be normal beats, and then murmur will be added. Listen carefully. I'm going to ask question, which murmur is this?
Carotid artery, especially the right carotid.
Okay. Can write the response. Write, like suppose if it is a mitral stenosis, don't put space between mitral and stenosis, write in a straight line, mitral stenosis without the space. I'm just giving example. Which murmur is this? Try to write it. So where was it located? it was location is going to help you. And go with that, yeah. Looks like you guys are getting it. Go. Majority of us think it's aortic stenosis. Then a few of us thinks it's MR. Few of us thinks it's pansystolic murmur. Okay. So do you guys want to listen it again? So what we were hearing was, it was a harsh systolic murmur, right? Just remember this figure and then try to listen that again.
Best at the second right intercostal space and does not change with respiration. It may radiate to the carotid artery, especially the right carotid.
Okay, so it was a harsh systolic murmur. And anytime it says it's radiating to carotid, it's aortic stenosis. That is another clue, the radiation. So usually if it is severe, you won't be able to listen, you won't be able to hear this S2. In this particular one, there was S2, but it was really soft. So if it is like severe soft S2 or absence of S2 states that it's severe. So based on examination, you should be able to tell aortic stenosis. It's one of the most common murmur that you're gonna hear, particularly in the elderly patient. If it is related with bicuspid valve, there will be a click. We will listen to another click later on. So click usually comes after S1. You'll hear tuck, tick, tick, and then you'll hear the murmur. So first sound will be S1, then there will be click and there will be murmur. Okay. So murmur is kind of practice. For decoding the question in exam, if you just follow those 4 steps, you should be able to get almost all of those murmurs. In terms of like actually listening the audio, it's a practice. So I can send this presentation, or you'll have the recording. You can actually listen to these murmurs and have practice with that. Okay, this is another one. Again, it will be first 3 beats will be normal, then the murmur will be added. Okay. So again, next question. Which murmur is this? Good.
Can we hear the murmur again, Prakriti?
Yeah. Actually, I cannot go back while it's running. We'll have to wait 13 seconds and I can go back again.
Okay.
Doesn't matter. It's a process of learning. Even if you're wrong, you'll learn more. Okay. Here. So it's located in the apical region. So it should be some murmur related with mitral valve, right? And it's like blowing type, harsh murmur, and you can barely differentiate between S1 and S2. So this is a pansystolic murmur. Do you find difference between this murmur and prior murmur? In the aortic stenosis murmur, it was like murmur was, S1 was there, then murmur was gradually increasing, then coming down, and you can hear soft S2. But this, you can see continuous, like from S1 to S2, there is a continuous murmur. So this is a pansystolic MR murmur. Okay, it's holosystolic and it's constant. This murmur can be confused, particularly if it is AS murmur is radiating towards the sternum, or this murmur, if it radiates towards the sternum, you can get confused. But the best way to differentiate between aortic stenosis murmur and mitral stenosis murmur will be see the carotid. If it is going towards carotid, then it is mostly aortic stenosis. Mitral murmur doesn't radiate there. Mitral murmur, based on the which valve is involved, it can radiate to sternum or towards the axillary region. But try to find the difference between the two murmurs. Okay, this is again same mitral regurgitation, so we can see, but we discussed earlier, so I'm going to go forward now. Okay, this is one of the very important murmur. And I think this will be the second most common murmur you guys will hear. Let's hear, and I have a question on this too.
Normal beats, and then add the murmur.
Okay.
Normal beats, and then add the murmur.
So which murmur is this? The key is to differentiate if it is a systolic or diastolic, and you can do that by systolic murmur happens after S1 and diastolic murmur happens after S2. So that is the most important thing you have to know. Okay. So this was an innocent murmur. The reason I told you it's most common murmur, because anytime there is an hyperdynamic circulation, like hyperthyroidism, anemia, fever, or a pregnant patient, even in young patient who are like very active, you're gonna hear this murmur. This is an innocent murmur. I'm gonna play this again. You can clearly differentiate S1 and S2, and there's very brief blow in between.
Normal beats, and then add the murmur.
It's pretty brief, not like blowing or harsh. Okay. So the reason it is important to differentiate innocent murmur is because you don't need to evaluate this innocent murmur. You need to evaluate, so anytime, so mostly innocent murmurs are systolic murmur. And they're very brief, very small, and you clearly have a reason. It will be hyperdynamic, or the patient is like active, pregnant, anemic, hyperthyroidism, fever. So if you have a reason and it's a 2/6, so anytime it is less than 2 grade, you guys know the grading, right? 1 is barely audible, 2 is audible to normal with stethoscope, 3 is but 2 is still difficult. 3 is you can easily through the steth you can hear that. 4 is little louder. 6 is 6th grade is like you can hear from far. Even and 5 is you can hear it even when the steth is not on the chest but just close to chest. And 6 is like you can really hear from very far. Most of the murmur we hear in our daily life or examination is usually grade 2 or grade 3 murmur. Sometimes you get grade 4 in very severe disease. So important thing is like anytime you have systolic murmur less than grade 3, or if you have grade 1 or grade 2 systolic murmur, try to find if it is an Inoshian murmur. If it is an Inoshian murmur, you don't have to evaluate further about it. But any diastolic murmur is always a pathological murmur. So you have to further evaluate that. And any systolic murmur, which is more than 3 grade, you have to evaluate that. The grade is how they have defined it. It's very confusing and it's perception too. Like sound त्यस्तै हुन्छ हैन, कुनै साउन्ड मेरो लागि चर्को हुन सक्छ, अरूको लागि सानो हुन सक्छ। त्यही भएर त्यो ग्रेडिङ चाहिँ एकदमै ग्रेडिङ त्यसरी गरे हो त त्यो अलि गाह्रो छ। आफ्नै इयर अनुसार सुने के, इट्स नट लाइक स्ट्यान्डर्डाइज्ड। तिमीलाई फिल हुँदाखेरि त्यो मैले अलि मेहनत गरेर सुन्नु पर्यो जस्तो लाग्यो भने इट्स लोवर ग्रेड हैन। यो मैले स्टेट तल राख्ने बित्तिकै मैले सुनिहाले भनेपछि इट्स हायर ग्रेड लाइक 4, 3, 4, 5।
Normal beats and then
okay, so this is another murmur. Listen nicely. And anytime you get this in real life, you won't get this like when you are listening to the patient, it will never always start with the systolic, but in examination all the murmur always starts with S1. In real life, if you want to see if it is S1 or S2, if you can feel the pulse, that will be S1. So you can put a stent in the chest and then put a finger on the pulse. If you can correlate that pulse with that beat, then that is an S1 beat. Okay. And in examination, you always get it from S1 because all the recording they do is from S1, S2. So if anything comes after only 1 beat, that is a systolic. If anything comes after 2 beat, that will be diastolic for exam purposes. Okay, so this is kind of position, based on position, it is very easy to say it's in the apical area and the patient is left lateral. So if it is apical, it must be mitral murmur. And because patient is lateral, it is one of the difficult murmur to hear. And it's very rare that we hear unless the patient has severe mitral stenosis, or if you really put the patient in the lateral position and hear this. So this is a low-pitched diastolic rumbling murmur. That is why you heard like there was something singing, like seagull was singing type of sound there, like multiple beats, because one of them was S1, then came the S2, and then came opening snap, and then was the murmur. So there was a lot of tick, tick, tick before actual murmur started. And now I believe you can differentiate between mitral stenosis and mitral regurgitation, right? It's like clearly different, but feel free to take this presentation. And if you want to hear this over and over again for practice. Okay, so this is another murmur.
Recorded at the 4th left intercostal space.
So this was again a diastolic murmur.
Recorded at the fourth left intercostal space. Recorded at the fourth.
So here it was like S1, there was S2, which was loud, and then soft, slow, decredent, like blowing type of murmur. This was AR murmur. So these are the four murmur. If you can remember these, it's super easy to differentiate. These are the only four murmurs you're gonna hear most of the time. You are going to hear tricuspid murmur as well. But the tricuspid murmur is exactly same as mitral. Tricuspid regurgitation murmur is exactly same as MR murmur, just the location is different and it changes with respiration. We'll talk about that dynamic auscultation a little later, but it changes with auscultation. So if you can remember aortic stenosis, which is the most common you're going to encounter. For exam purposes, if you follow all those four steps, you will kind of crack almost all the murmur which is given because they give description. And if they give the sound, just based on the description of other thing, you should be able to find out. For real life, if you can remember aortic stenosis murmur, which is the most common you're going to hear, and second most common is mitral regurgitation murmur and innocent murmur. So those are the three. If you can remember, you should be able to take care of most of the patient. And so I did not keep the pulmonary murmur and tricuspid murmur because even for me, how I remember is pulmonary murmur and pulmonary gradients and everything is exactly same as aortic. It's just gets corresponding. They go, both are outlet murmur, everything goes together. So aortic stenosis murmur is exactly same as pulmonary stenosis murmur. The only way we can differentiate those two is from the respiration, which is a dynamic auscultation. We'll talk about that. Okay, and then MR for tricuspid murmur and mitral murmur, they just go together. They are exactly same. So MR murmur is and TR murmur is same, just the location is different, just how they behave during inspiration is different. Okay. So these are some extra thing. It's not a murmur, it's just extra heart sound. This is a third heart sound. I'll open it. Let's. Okay, so here most of you might have noticed it goes with the cadence of the word like Kentucky. So now if you hear it, it's like Kentucky, Kentucky, Kentucky. It goes that way. It's easy to remember that way. So Ken is the S1 part of it and Tucky is like S2 and S3 goes together. So if you can say that when you are hearing that, then it's probably S3. Next one, this is S4. It comes before S1. So this was like how it was Tennessee. So I will put that again. So this 10 sound is actually the S4 and Nessie is S1 and S2. That is how it comes. If you, when you are hearing, if you put that Tennessee in your mind, you can just remember it. Tennessee. Okay, it's a practice, but you should be able to get most of it. This is pericardial drop. And pericardial drop can be either systolic or diastolic. It's just a scratchy sound. Like you must have heard it in your by your teachers, like you just take a paper and scratch it. That is exactly what pericardial drop is. You feel like there was hard sound and there is something scratching throughout. Okay, so this is just a like scratchy type of sound. One clue I'm gonna give you is it's kind of cheating method in examination. If a patient is of pericarditis and you hear a rub in practical exam, you say, I hear a rub, and your attending comes and says that, no, I don't hear a rub, then you can easily say that rub is changing. It doesn't stay there. Rub never stays there. So I heard it. You may not have heard it, but you have to be sure that it's a pericarditis though before that. Okay. So yeah, so this rub, it's like, sometime it happens, like attending comes and says that, oh yeah, I can hear a rub here. But the resident or fellow says, no, I did not hear anything. So it does happen. It's true. It's not that they're lying, but rub can disappear within like 10 minutes. So like within like 5 minutes, in fact. I had a case where I heard a murmur, heard a rub, started the treatment of pericarditis, and then my attending comes and says like, I don't hear the rub, and it was, the difference was 10 minutes difference. But we treated for pericarditis and patient was perfectly fine. He got cured. So probably I heard correctly. That was initially when I was a resident. Okay, so now, and this is a summation gallop. This is going to be like, this summation gallop is S4 and S3. All are present. It will start with S4, S1, S2, and then S3 will be added in this video. So this will be pretty much, because this was started with 10 S4, so it was like 10 SC. How I was thinking through is like 10 SC, 10 SC, and suddenly one beat was coming, 10 SC, one beat, 10 SC, one beat. That is how it sounded to me, like the summation gallop. Okay, so now there is two conditions which have a murmur, and which often is like is important because we have to differentiate between that. One of them is hypertrophic obstructive cardiomyopathy. It is important because this murmur behaves kind of different. So what exactly happens in hypertrophic cardiomyopathy is this walls are thickened. So because these walls are thickened, so anytime there is LV size which is small, if this LV size is small, then when the blood will flow through this, then there will be turbulence. So there will be murmur. So the murmur for hypertrophic cardiomyopathy is exactly like aortic stenosis murmur, except that it has some difference in dynamic auscultation. Okay, so when things to remember is when the LV size is small, aortic Hookham murmur is loud. When LV size is big, because there is less narrowing, so Hookham murmur will be soft. Okay, because if LV size is big, then the outlet obstruction will be less. So big LV size, less murmur. That means, so to have a big LV size, what you need is you have to have more preload. So preload is the amount of blood that comes in the heart. So if the blood that comes in the heart is more, so LV will be dilated more. So if the preload is more, the murmur will be less. If the preload is less, the LV is less dilated, then the murmur will be more. Okay, this is pretty much same thing with afterload too. So if afterload is more, the heart have trouble pumping the blood. So more blood will remain in the heart. So if afterload is more, the murmur will be less because LV size will be bigger. But if afterload is less, afterload is the resistance outside the heart. So if resistance outside the heart is less, then blood can easily flow out of the heart. So if blood can easily flow out of the heart will be small, so the murmur will be loud. I have some more diagrams later on to help you. So this murmur is actually the Hocum murmur. Hocum murmur is exactly same as AS murmur. It's like it will be difficult to differentiate it with AS without the dynamic auscultation. So now let's decode the dynamic auscultation. Few things you have to remember is, first thing, if the blood flow is more, the murmur will be more. That goes for stenotic murmur or regurgitation murmur. The reason is if the blood flow is more, there will be more turbulence, more कुनै पनि ठाउँबाट बढी पानी बढी त्यो पानी गयो भने त्यसमा पनि के भन्छ पाइपमा पनि पानी बढी गयो भने मर्मर ठुलो लाउड हुन्छ नि, त्यही हो कि बडी ब्लड छ भने बडी मर्मर हुन्छ, त्यो पार्टबाट बडी ब्लड गयो भने. सेम वेनस रिटर्न अघि भने जस्तै if the preload and the afterload changes, the murmur intensity changes too. So preload is equivalent to the venous return. It's the amount of blood that comes in the heart, and afterload is the peripheral vascular resistance. It's the resistance that the heart have to undergo through in order to pump the blood in the body. So inspiration, what happens in inspiration is there is a two mechanism going on. I'm going to play a video and then explain. So here. So in this video, you can see that this is a deep inspiration. So this is a deep inspiration. So you can see that the diaphragm is flattened, and diaphragm is flattened, the pressure inside the intrathoracic cavity will be less. So if the pressure inside the intrathoracic cavity is less, then blood always flow from higher pressure to lower pressure. So if the pressure inside the intrathoracic cavity is less, then more blood will come in the heart. Okay, so during the inspiration, more blood comes in the heart. So right side murmur will receive more blood flow. So when right side receive more blood flow, all the murmurs in the right side is going to increase with inspiration. Okay, and left, what happens to left side murmur is that is a low pressure area, and it have to pump blood towards the high pressure where in the abdomen and other part, because thoracic is a low pressure during inspiration. So all the left sided murmur blood doesn't flow much because it has to flow from lower pressure to higher pressure. So it doesn't flow much. So during inspiration, the blood flow through the left side of the heart valve decreases. So that is why left side of the heart murmur doesn't increase during the inspiration. So anytime there is an augmentation or increase in the murmur with inspiration, then it is a right-sided murmur. This is how you can differentiate between mitral and tricuspid murmur. Otherwise they are same. The only way you can differentiate is through the inspiration. Okay. So exactly same thing, the intrathoracic pressure decreases. So blood flow to the right side of the heart increases, and the blood flow to the left side of the heart decreases. That is why right-sided murmur increases during inspiration. Okay, now the concept of preload and afterload. The preload is the volume of the blood in the ventricle at the end of the diastole. So it depends on how much blood is poured inside the heart. And afterload is the resistance that ventricle has to overcome. So it depends on what's the peripheral vascular resistance. Afterload depends on peripheral vascular resistance. So now this is very important to understand the concept of preload and afterload, because we need to know what changes what. In dynamic auscultation, you might have always heard that, okay, amyl nitrate increases the murmur or decreases the murmur and all those parts. So, but why does it increase the murmur or decrease the murmur? So amyl nitrite is a vasodilator and arterial dilator. So it's going to dilate the vessel. So it's going to decrease the peripheral vascular resistance. So it's going to decrease the afterload. That is what it does. Hand grip is pretty much like if you make a hand grip, so it's like a knot. So if you make a knot, the resistance is increasing. So hand grip actually increases the peripheral resistance. So it increases the afterload. Valsalva, this is very important. So this is exactly reverse mechanism from the inspiration. So what we do in Valsalva is we take deep breath and then we hold the breath in there. So at that present, we have like all the air inside our heart, inside our lungs. So actually respiration, sorry, when we are blowing, take deep breath, and then we blow it and then we hold it in the blowing phase. So the diaphragm is not flat, it's curved. Diaphragm is curved. The pressure, all the air inside the heart is in there. So we just before the expiration, we held it. So it was in the process of expiration. So the pressure inside the intrathoracic cavity is actually very increased during the Valsalva. That's the straining phase of Valsalva. So when the pressure inside the thoracic cavity is increased, the flow in the thoracic cavity will decrease, right? So because the blood flow from higher pressure to lower pressure, the pressure inside the thoracic cavity is high, so the blood will have trouble going in, so the flow will decrease. So Valsalva decreases the venous return and then thus the stroke volume and preload, okay? The squatting and standing is pretty much like I'd say making fists. So when you are squatting, you are technically folding your legs and everything and your hands. So it's kind of making knot. Just remember, like you're just kind of folding your legs, so you're kind of making knot. Anytime you make a knot in a pipe, you are increasing the resistance. So afterload is increasing. And preload increases too, because all the blood vessels doesn't have to work against the gravity to come to the heart, because the gravity will be less when you are sitting down. So if gravity is less, vessels doesn't have to work against the gravity, so it can flow easily in the heart. So squatting increases both preload and afterload, and standing is exactly the reverse. When you are standing, the peripheral vascular resistance is decreasing, the blood have to fight against gravity, so both preload and afterload decreases with standing. Okay, so these are the mechanism. You probably have to go through this again, just think through it by yourself, because that is always helpful. And this is one thing which is used in cath lab and also in real life. Sometimes if you are lucky and you are getting PVC in the EKG, to differentiate between Hooker murmur, that is hypertrophic obstructive cardiomyopathy murmur, without stenosis murmur. So this is a PVC. So you can exactly see this, you can normally see what is PVC. It's a premature ventricular contraction. So this heart just contracted. Then even before it was supposed to be contracting, it got another extra beat of PVC. So now heart is refractory. So obviously there will be a long pause between this PVC because heart is refractory. So it's taking, it's a compensatory pause. So it's trying to recover from it. So while heart is taking long time, there's long time for heart to fill in. So the next beat when it comes, it's gonna be harder because preload is gonna be more at that time. And it's so hard. So just imagine that preload is more, so LV is bigger. So if LV is bigger, then the Hooker murmur is gonna think about it. So the post PVC, the contractility of heart is increased because it heart, and then afterload is decreased as well. And preload is increased there. So this is another important thing which often get confused with MR. It's a mitral valve prolapse. Here's the picture. I will be honest, I did not even know this pathology when I was in med school. we don't see that much. Part of it is we don't probably recognize it much there. The prevalence is pretty high, up to 5% people have these, but we don't recognize that much in med school. But prolapse is what if heart when closes, it has to be closing this way, but instead it just bulges in the right atrium. So that is called mitral valve prolapse, and we read about it all the time. So when it prolapses, when it is thick, and when later on, initially you don't have murmur much here, but when this valve get thickened, so it's when it prolapses, there's some leakiness, so there will be a murmur, which is pretty much like MR murmur. The only difference is MR murmur is pansystolic. The murmur with the prolapse is not pansystolic. It is followed by a click, because this valve actually, when it opens against the atrium, it's like very quick, swift. So you hear a click and then you hear that murmur. So mitral valve prolapse, it's kind of easy way. I'm going to give you an easy way. So with mitral valve prolapse, exactly same like Hookham. If the LV is big, the murmur duration will be less. If the LV is small, the murmur duration will be more. So here, if the LV size is big, like when we squat, the LV size is big, so the murmur duration is small. And if we are standing, the LV size is small, so murmur duration will be more. We know this all, like this is all mechanism, but in examination, you cannot really go through all this mechanism to remember sometime. So a quick thing to remember is when you squat, this is the most common thing you get. When you are squatting, your height is decreasing. So just remember, squatting means decrease in height. So decrease in Hookham and MVP murmur. MVP is mitral valve prolapse murmur. This is more for examination point of view, and for quick MCQs, like decrease in height equal to squatting. So decrease in Hookham murmur and decrease in mitral valve prolapse murmur. Okay. Okay, so this is a big list of all the mechanism, how we talked about it. We can go through this. So what does Valsalva and standing does? So Valsalva increases the intrathoracic pressure. So it decreases the return to the LV. So it's kind of decreasing the preload. And standing, because of the gravity, it is decreasing the preload. So when preload is decreased, the heart is small. So Hookham murmur will be high. Mitral valve murmur will be high. And the heart is small, less blood. So less aortic stenosis, less mitral regurgitation, because less flow through blood. So this is how you can go through all of these. I can go through it, but I think I am exactly at 1 hour now. So if you guys want me to go through each line, I can, or we can stop here. Okay, I'll just go through. Seems like you guys are going. So what is laying down? Laying down is just sleeping. So you don't have to fight against gravity. What is squatting? You don't have to fight against gravity. Straight leg raising test, gravity start helping you. So all these things are going to increase the flow of blood inside the heart. Anytime flow of blood inside the heart is increased, so heart volume is high. When heart volume is more, Hookham murmur is more. When heart volume is more, Hookham murmur is less, and mitral valve prolapse murmur is less. If heart volume is more, there is more blood. So more blood will pass through aortic valve. So aortic stenosis murmur will be more, and more blood will pass for mitral valve. So mitral regurgitation murmur will be low. Will be more. So dynamic auscultation, otherwise you can easily differentiate MS and all those. The main confusion lies between Hookham and AS, because Hookham and AS murmur is exactly same, and mitral valve prolapse and MR murmur. So usually dynamic auscultation is to differentiate these two murmurs. Then if there is a hand grip, a hand which is kind of making a knot, so it's increasing the afterload. When afterload is increased, blood cannot flow out of the heart. So heart is going to increase in size. If heart size increases, the Hookham murmur is going to be less, because there will be less obstruction. If there is an increased afterload, less blood will flow through aortic stenosis. So aortic stenosis murmur is going to be less because heart sound is less, because the heart volume is more, mitral valve prolapse murmur will be less. And because there is a resistance coming out of the heart, so all the heart blood is going to return back towards the mitral valve. So flow across the mitral valve is going to be more. So mitral regurgitation murmur is going to be more with increase in afterload. That is by hand grip, which is like a making knot. And phenylephrine is actually alpha receptor agonist, so it just contracts constrict all the vessels, arterials. Phenylephrine is used for mostly for hypotension, especially in aortic stenosis, because aortic stenosis, you cannot use anything which is going to increase the contractility, because if you use Levophed or epinephrine or norepinephrine, it increases the contractility. So aortic stenosis get worse. So patient is going to be more hypotensive. So you want to use something which is going to increase the afterload so that the aortic murmur become decreased. So any patient who go for surgery, have a history of aortic stenosis, you always recommend to use phenylephrine for the person who have anesthesia exam tomorrow. Okay, then amyl nitrite. Amyl nitrite is nitrate. It's a vasodilator. So it's going to decrease the afterload. So anytime afterload is decreased, aortic stenosis murmur is going to increase. Afterload decrease, so more blood comes out of the heart. So heart is small, so Hocum murmur will be more, MVP murmur will be more. If all the blood will come outside the heart, so there will be less blood to flow back towards the mitral valve. So there will be mitral regurgitation murmur will be less. Okay, pretty much we talked about the PVC, how it works too. So PVC, one thing good to remember is PVC is only used to differentiate between Hocum and AS. PVC doesn't have any, technically it doesn't have any effect on MVP and mitral valve. It's very minimal effect. It's not like so drastic effect. So anytime they are talking about PVC, they are trying to talk, anytime they are talking about PVC, they are trying to tell you more about these two, but I don't think you guys will be asked. This is more of cardiology board, because in cath lab, we use this to differentiate this Hocum and AS. So for you, you don't need much. You just need up top 1, 2, 3, 4. This is the same thing. Okay, now we go to the poll question and we will quick. These are the same question we did earlier. So I don't have to wait much. Here is the question. Which murmur needs to be evaluated? You have 24 seconds. Which murmur needs to be further evaluated? Okay. Okay, better than earlier. So yes, 2 by 6. So this is the correct answer. 2 by 6 diastolic murmur. Any diastolic murmur need to be evaluated. So talking about any murmur in young patient need evaluation. So young patient like this 25-year-old pregnant female, she can have innocent murmur. Young patient can have fever, so they can have innocent murmur. So that is why that part, this is not correct. So they can have some innocent murmur, but anytime you hear diastolic murmur or anytime you hear murmur more than 2, more than grade 2, in any patient, no matter what, it's young patient, old patient, you are going to evaluate that. Okay, so. If I can go forward. Okay, this is the second question. I'm expecting to get completely right in this question. 100% correct. 13 more seconds. One second. Okay. So yes, the correct answer is diastolic murmur. Why? Because when stenosis murmur occurs when the valve is open. When is mitral valve open? Mitral valve is open when the heart is receiving the blood. So when heart is receiving the blood is diastolic phase. So you will hear mitral stenosis murmur in diastolic phase. Okay. Okay, this is hypertrophic obstructive cardiomyopathy murmur decreases with. $18 more seconds. Okay. Sorry. So this one is, the correct answer is with hand grip. It's decreases. So with hand grip, because there's a resistance like not, so peripheral vascular resistance is increasing. So less blood will flow out of the heart. So heart will be dilated, LV will be dilated. Anytime heart is bigger, there's more blood in heart, the Hooker murmur decreases. So this decreases. For PVC, because the afterload is going to increase. So when afterload increases, the afterload is going to decrease in post PVC. So when afterload decreases and contractility increases, more blood will flow out of the heart. So the post PVC Hooker murmur is going to increase. Valsalva, again, the pressure inside the thoracic cavity is more. So less blood will flow inside the heart. So when there is less blood, the LV is small, so murmur will be more. Just remember relation with the LV size, then it's easier to remember. It's confusing. You won't get it in first time. Don't get frustrated, but you'll get it. With standing from sitting position is again, it's gonna standing decreases the preload, decreases the afterload. So the blood inside the heart is gonna be less, because there will be less flow inside the heart and more flow outside the heart. So volume of the LV is small, so the murmur is gonna increase. Okay, so this is the last question. Here. I'm almost done. 26 more seconds. Okay, so it's a systolic murmur, same concept, and you guys did great actually. I have some of you who is just first year and second year, so I don't expect all of you to know everything with one lecture, but you guys improved in almost all the question after the lecture, so you guys really paid attention and did great. So aortic stenosis, same concept. Stenosis murmur occurs when valve is open. Aortic valve is open when the blood is coming out of the heart. So it will be outlet valve. So aortic murmur opens in systolic. So aortic valve opens in systole. So aortic stenosis murmur will be systolic murmur. And I have take-home point. So just remember, even if you don't remember anything, just remember this thing, and I'm sure it will be easy for you next time. So stenosis murmur occurs in open valve. Regurgitant murmur occurs in closed valve. And change in preload and afterload changes the intensity of murmur. This is all you have to remember, at least minimum. So I have 3 questions, which is kind of for me, for my.
अहिले चाहिँ नेपाल जस्तो डेभलपिङ कन्ट्रिजमा एकदम यङ मान्छेहरू जस्तै अब मिड 20s लेट 20s मै एकदमै नै एमआई देखिरहेको छ. सो सबसे इम्पोर्टेन्ट कज चाहिँ यसको लागि के होला जस्तो लाग्छ हजुरलाई?
Okay. यो चाहिँ big research को कुरा हो, थाहा छ. They have like done bunch of research on this. Usually lipid को नयाँ guideline पनि आएको छ है. Mostly we don't focus towards the preventive health. That is number 1. Number 2 is our dietary pattern, lifestyle, everything is changing. Okay, I mean rich lifestyle भनेर चाहिँ everyday मासु खाने, टन्न चिल्लो पिरो खाने, रक्सी खाने त्यस्तो हुन्छ नि त. Rich lifestyle भन्दै अनि exercise हुँदैन, most of the work table work हुन्छ, अनि त्यो lifestyle change भयो. अर्को चाहिँ somehow we South Asian को चाहिँ हाम्रो like जीन नै प्रब्लम पनि हो के भन्यो भने साउथ एसियन जीन भनेको चाहिँ एउटा कार्डियोभास्कुलर रिस्क फ्याक्टर नै भनिन्छ. लाइक लिपिड प्यानलमा पनि मोस्ट अफ द साउथ एसियनहरुको चाहिँ लिपिड एलपी लिटिल ए भनेर एउटा टाइप हुन्छ, सब टाइप हो लिपिडको, त्यो एलिभेटेड हुन्छ जसले गर्दा मायो एथेरोजेनेसिस बढी हुन्छ साउथ एसियनमा. त्यही भएर न्यू लिपिड गाइडलाइनमा चाहिँ उनीहरूले के गरेछ भने तिम्रो एएससीबीडी त्यो एथेरोस्क्लेरोटिक कार्डियोभास्कुलर एन्ड स्ट्रोक रिस्क क्याल्कुलेट गर्दाखेरि यदि साउथ एसियन पपुलेसन इन्टरमिडिएट रिस्कमा आयो भने पनि तिनीहरूलाई स्ट्याटिन चलाउन भन्छ, वर्सेस कि अरू कोकाजियन पपुलेसन, अफ्रिकन अमेरिकन पपुलेसन अथवा युरोपियन पपुलेसन उनीहरूमा चाहिँ हाई रिस्क भयो भने मात्र स्ट्याटिन चलाउन भन्छ के. सो हाम्रो जीन पनि एउटा रिस्क फ्याक्टर हो. On top of it, we are just changing our lifestyle, not in a good way.
What do you want to tell your younger self? जस्तै medical student मा बसेर पढिरहेको प्रकृतिलाई, what do you want to tell her?
I want to tell her that same thing I mentioned earlier is medicine घोक्ने मात्रै हुँदो रहेनछ. बुझ्यो भने you can do much better. घोक्यो भने you'll just forget after exam. मैले पनि त्यही गरे हो, honest हुन्छु, मैले पनि त्यही गरे हो. घोकियो त्यसपछि बिर्सियो, तर त्यो बुझेर टाइम दिएर पढ्यो भने चाहिँ राम्रो हुन्छ. One another thing which to be honest I did mistake and I realized during the examination time actually पहिलादेखि पढ्नु पर्ने रहेछ. Just give 1 hour every single day no matter what, and then it's like exam time मा चाहिँ टेन्सन हुँदैन के. त्यही हो मेन के. त्यो चाहिँ एकदम इम्पोर्टेन्ट कुरा हुँदो रहेछ. त्यो मैले अहिले ठ्याक्क बहिनीलाई स्टार्ट गर्दा पनि बहिनीलाई त्यही भनेको थिएँ रेजिडेन्सीमा, नो म्याटर वाट यु डु 1 hour every day for your books. That's our life. Thank you, Didi, for inviting me, and it was really wonderful meeting all of you. If you guys have any question, feel free to contact me, and my email address is drprakritiurja@gmail.com, so it's kind of easy to remember.
Thank you so much, ma'am, for joining us. It was wonderful having you here today with us. And I would also like to thank Jagdamba Pandit ma'am for arranging all this for us. We had a really good time. And also thank you to my co-host, Neeraj Dai. You were wonderful. Thank you.
Thank you.
So I think with this, we'd like to end this session. Thank you all for joining us, and have a great day ahead. And I think we'll be doing this kind of program in days to come as well. Once again, thanks to Dr. Prakriti and Dr. Jagdamba. You guys are very wonderful. And with this, let's end this session.